I would like to invite you to the next presentation. Docent David Kemlink from General University Hospital in Prague, Czech Republic. And his presentation will be focused on current trends in respiratory care for advanced stages of neuromuscular disorders. I think it's a very interesting topic, and I will have some questions also to docent regarding the access to care of, especially in respiratory care at home. Thank you very much, and the floor is yours.
So good morning. Thank you for inviting me to this forum. In the beginning, I would like to say that I will not speak exclusively about SMA. This talk will be a little bit more general on all other types of neuromuscular disorders. I would like to stress several points because the respiratory support, and not just respiratory, but also airway clearance support, is very important in advanced stages of neuromuscular diseases. So our first focus is to early detect the signs of weakness of those muscles. Second point is the monitoring of compliance of effect of the measures that we have initiated for the patients, to see if we are really doing the desired changes. The third topic will be to mildly stress which important issues the patients with advanced stages of neuromuscular disorders frequently face, and how are the centers trying to help them. And the last short point will be about some ethical issue, because my talk is a little bit different from the previous ones, and of course our patients are much older, and we also have to admit that there are some issues about the end-of-life treatment. First, why do we need to screen for respiratory failure in the neuromuscular diseases? Because the point is, as I mentioned before, that respiratory failure, pneumonia are the leading causes of death in patients with neuromuscular disorders. And actually, some forms of impairments of breathing at sleep worsen also cardiac failure, which in, for example, with Duchenne muscular atrophy, are also frequently affected, and also the cardiac failure is a frequent cause of death in patients with myopathies. These points are treatable, as we have heard in the beginning of this whole conference. Not all diseases are curable, but most of them are treatable. So we also can offer our patients some mechanical assisted ventilation and airway clearance techniques. The airway clearance decreases morbidity and mortality, hospitalization rate, and non-invasive ventilation can be maintained the quality of life of our neuromuscular patients for months or years, much longer than probably with the invasive ventilation. Of course, invasive ventilation in some diseases like amyotrophic lateral sclerosis can lead to almost doubling their survival than without this type of treatment. A little bit slow on switching the slides, I'm sorry. Okay, so this is example of devices that we use in patients with advanced respiratory failure. All those devices have specific modes for non-invasive, invasive, and mouthpiece ventilations, which can help patients to be ventilated by their preferred forms with switching of different interfaces and as much prolonging the need for chronic tracheostomy as long as possible. So, on the other hand, when the necessity for and choice for invasive ventilation would be made, then the patients can keep their equipment which they are used to and continue with different types of ventilations. All those devices are types of life support ventilators, and they are certified for continuous use with invasive or non-invasive ways of ventilations. There are many trends in most of neuromuscular diseases to keep patients with non-invasive ventilation as long as possible. We believe that the majority of patients with neuromuscular diseases can nowadays be continuously ventilated by those measures without need of tracheostomy and invasive ventilation. There are some exceptions in diseases like amyotrophic lateral sclerosis, but even in SMA1 patients, we can achieve long-term ventilation by non-invasive measures, which improves the quality of life and decreases in the complications of the ventilatory care. The second question is how to best screen for respiratory muscle weakness. So, as was already mentioned in your previous presentations, the basic pulmonary functional tests, namely forced vital capacity, are the most important one and should be initiated very early in the childhood, that the patient would be trained for those tests, and thus the force serves as a long-term value passport of their respiratory muscle fitness, and the early detection of the decrease of this parameter is very important to start with other measures. Second very important pulmonary function test is the peak cough flow, which would correspond to use of cough assist and airway clearance techniques, and they're also quite easy to do with simple devices. More advanced test would be a testing of blood gases. We would probably, the patients also would prefer to use non-invasive measures like percutaneous testing of oxygen saturation and partial CO2 levels. At the stage of the patients which are at the sitting condition, which no longer are able to walk and very frequently are no longer able to move their wheelchairs by their own strength, we recommend to do regular sleep studies. The reason is that in REM sleep, we can most sensitively detect impairment of ventilation, because in this condition over the daytime, the blood exchange of the oxygen and CO2 is most impaired, and the ventilation is the weakest during the 24-hour period, making this test very sensitive. So how does a sleep study happen? It is a combination of multiple measures. This is just for illustration that the patient has a room with many interfaces measuring EEG, EOG, EMG, ECG, saturation, and sometimes even other conditions to be able to detect precisely also the sleep stages. So once we have screened the patient, and in those patients who are indicated for non-invasive ventilation, we have started chronic ventilation either only nighttime, but in some patients only during the daytime. We need to strictly monitor the effects of our interventions. So there are several types of visits that we would recommend. First, we ask patients to come for regular follow-ups. Usually, we would perform blood gases examinations and sleep studies and pulmonary function tests together with download of data from their device. Very frequently, we add percutaneous capnometry during our examination and the night video polysomnography that we do in our hospital. But in some centers, also a home-based examinations are available. We also review the summary data from our patients when they would contact us with some problems. So we have a continuous approach to some of our patients due to telemetric medicine measures. So blood gas analysis are either done, as I mentioned, non-invasively with capnometry, or invasively from best arterial blood samples, or sometimes capillary blood samples. But our most frequent and most comprehensive type of investigation is polysomnography, which along with EEG can detect changes in respiration. This is an example of a patient with a neuromuscular disease and hypoventilation happening during his REM sleep, and also there are already evident drops in his saturation and frequent awakenings, which would further put more stress on his respiratory system. Same patient in REM sleep with a little bit more zoomed in technique would show us the awakenings that we can detect in our patients, again leading to decreased quality of sleep and daytime symptoms. This is an example how we test the effectiveness of non-invasive ventilation, and we can also directly measure the pressure inside of the patient's mask, and to test if the respiration is effective and regular. So we may in a real time adjust the settings of devices to best provide their ventilatory support also when the patient is sleeping and cannot report his problems. Most advanced ventilators for nighttime or also daytime use record almost every breath of the patients between the regular checkups when the patient would be coming to our hospital. So we review those records over several months, and we can also check individual nights, which would show some summary pathologies. So basically, we can have a several months recording and to have a look at the areas when the patient would start to have problems and try to find solution for these abnormal findings by changing the settings of the device. And when the patient is also present in our hospital. As I already mentioned before, capnometry is the real-time capnometry is one of the most useful tests to assess the quality of ventilation in our patients. So, as I've shown before, the CO2 levels can start to climb when the patient is not breathing well. On the other hand, with good settings of the device and good toleration of the non-invasive ventilation, we can keep stable values of CO2 levels along with regular respiratory patterns in our patients. But sometimes the initiation of extra pressure to the patients can lead to complex sleep apnea, which needs to specific approach and change of the respiratory support. But eventually, also when we are aware of this condition and we have frequently followed up the patients, we can also in those patients lead to good compensation with very nice values of CO2 levels during the daytime, and again respiratory patterns that would not lead to multiple awakenings and not produce the daytime symptoms in our patients. As I already mentioned, we frequently use telemetric systems that allows us to communicate with the device that the patient has at home. We can retrieve some summary data from those devices and according to it also change the settings of the device to provide improvement in the patient's compliance and tolerance of the device. We always need to have feedback from the patient, and we always have to inform the patients about the changes that they made. So this electronic online systems are of course not meant to be used without the patient's interaction, because their feedback is one of the most important information that we need as an input to change the ventilation regimes and to compensate for the daytime symptoms. Sometimes the capnometric findings which have been done at home. This is the example of an offline overnight recording in a patient can reveal surprising complications only during a half of the patient's night. So long-term monitoring is always useful and will show us that sometimes the patient have problems only during limited times of the day and being completely without major symptoms at most of the day and even in half of the sleep. Again, patient with non-invasive ventilation, when we can download online without the necessity for the patient to come to our centers that we can detect problems when the patient is not breathing very well, and that there are big differences during the daytime and nighttime even. So when the patient would report problems with his ventilation, we can detect in a quite nice report their problems and to change their settings accordingly with the cooperation from them. Currently, we are one of four major centers in Czech Republic which provides non-invasive ventilation for neuromuscular patients. We mostly treat patients with Duchenne muscular dystrophy, SMA, and is our second most frequent diagnosis. Usually, those patients would be also somewhat older than patients with Duchenne muscular dystrophies. And all these patients are with or adult patients are with other myopathies, and the most fluctuating group of patients is the group with patients with ALS, where we also sometimes need to switch to tracheostomy and invasive ventilation because the involvement of bulbar functions in ALS patients is most severe, and swallowing problems are one of the leading symptoms in this population, also limiting use of non-invasive ventilatory support. And the fourth topic that I wanted to cover are the other aspects of advanced stages of neuromuscular disorders which are related to respiratory care. So swallowing and nutrition are closely related functions to breathing. So usually muscle fatigue during swallowing would lead to weakness of respiratory muscles and vice versa. So we usually ask a patient to use ventilation, non-invasive ventilation, to give rest to their muscles so they could eat. And we ask them to use ventilators at daytime before and after eating to give them most strength to swallow as caloric nutrition as possible. But as some of the diseases would have a tendency to progress, we frequently would advise our patients to change the way of nutrition to percutaneous endoscopic gastrostomy, which is invasive procedure, but which can be taken along with non-invasive ventilation and is usually well tolerated by most neuromuscular patients. But along with non-invasive ventilator, gastrostomy is one of the most frequently given measures to advanced patients with neuromuscular diseases. Third, very related problem in advanced stages of those diseases is coughing and airway clearance. So stagnation of mucus and microaspiration like saliva very frequently lead to likelihood of chest and pulmonary infections, and they worsen the respiratory failure. And as I mentioned before, they are frequent cause of death in neuromuscular diseases. Besides preventive measures like maneuvers with the invasive ventilator, the mechanical insufflator, exsufflator, sometimes called a cough assist by the most frequently prescribed drugs, is most broadly used way to effectively clear the airways in patients who are very weak. And this technique can be used in both patients with non-invasive ventilation with a mask but it also improves the quality of life in patients with a tracheostomy, where it decreases the discomfort and pain caused by cannulary suctioning from airways, and thus also decreasing the likelihood of complications such as bleeding from trachea and bronchi, leading to major improvement in care for patients with very advanced stages and very pronounced muscle weakness. Mechanical insufflator, exsufflators are a little bit older images, but no longer under copyright, which is the device that we would most frequently use. And I believe that one of the most useful devices besides non-invasive ventilator to prolong and promote the quality of life in these patients. Today, we have already heard a lot about scoliosis and necessity of early surgery in the neuromuscular patients, because the impairment, further decrease in vital capacity would hasten the need for other types of ventilation, and of course decrease the effectiveness of non-invasive ventilation. So early surgery is something that we as a neurologist believe would potentially prolong the survival of our patients. As I also mentioned before, cardiac failure is associated to respiratory failure and also sleep apnea, as I've shown on the previous slides, with frequent awakenings also due to decrease in intrathoracic pressure, promotes cardiac failure and increases the likelihood of arrhythmias. And these conditions are closely associated to morbidity and mortality in neuromuscular patients and Duchenne muscular dystrophy patients especially. So monitoring of cardiac functions and proper treatment are very important components of the multidisciplinary care in advanced stages of neuromuscular diseases. In summary, the approach to those patients is very complex, requiring a big team of both physicians, physiotherapists, speech therapists, occupational therapists, for younger patients, also pedagogues, for the sitting patient, prosthetics, IT specialists, and engineers to promote the quality of life of older patients with neuromuscular diseases. We also would stress the need of social care and advices for those patients who are so disabled that they would require help in their daytime activities and are no longer able to also take for their financial problems. And as I mentioned before, some patients, namely with ALS, need very early information about the higher likely end-of-life to be seen by a palliative care specialist, which would sometimes help to cope with their difficult condition. So one of the last slides would be that progressive neuromuscular diseases, it's very important to early educate the patients about the outcomes which are expectable in those diagnoses, and to communicate what are their preferred ways of end-of-life decisions, and how would they prefer to have their invasive measures limited or decided for future. And the living will would be very helpful for many physicians seeing those patients at acute conditions. So a good plan for any condition always improves the quality of outcome of unexpected or expected conditions. So at the end of my talk, I would like to stress that in most patients with neuromuscular diseases, non-invasive ventilation is possible, but it is usually necessary to combine with mechanical airway clearance technique. That more advanced ventilators are very useful to provide long-term stable ventilation for patients with neuromuscular diseases. We profit from long-term monitoring of our patients with online application and telemedicine measures. But to stress the most important point is that a multidisciplinary care is very important for the quality of life of our patients. Thank you for your attention. I'm very sorry, but I have difficulties hearing anything, so I couldn't hear you if you asked.
Okay, again. Okay.
Yeah, better.
Thank you very much. Thank you very much for interesting presentation. I have two questions. We have two questions. One question is that you mentioned about the pulmonary or broader the care of patients regarding the any issues of pulmonary failure with different the neuromuscular disorders. It means that all patients in Czech Republic are covered by this care and they have access to the care also in hospitals and also at home, or do you have different access for, it depends on the region or type of the patients, how wide access is for this type of care in Czech Republic?
So I believe the access to this type of care is even. There are several centers which provide such care. Actually, Prague is one of for the western part, and Ostrava for the eastern part. Of course, there are some differences, and of course, different patients require different measures. But the baseline screening is mostly in the hands of pulmonary care or in physiotherapists. And once the screening is conducted, the patients are referred to the sufficiently wide centers with sleep medicine.
Okay, can you tell us more? Excuse me, I understand. Could you tell us about the prognosis or effects of respiratory care for patients with with patients with amyotrophic lateral sclerosis, ALS? What's your opinion about the prognosis for these patients in respiratory care?
Respiratory failure in patients with ALS is the most common cause of death. The point is that a non-invasive ventilation, which is our main measure in our center, is not very frequently effective. So we ask a patient to have their living wills very early to tell us if they want invasive or non-invasive ventilation. So in ALS patients, the survival with invasive ventilation can be twice as long as without it. So in some recent studies from Germany, the survival of ALS patients with non-invasive ventilation was about 40 months. but almost 80 months with invasive ventilation. But the invasive ventilation has its some costs. It is more unpleasant. The patients are limited in their communication, but of course there are many different types of patients, usually those with bulbar onset, but still preserved muscle strength of extremities would profit most from invasive ventilation, and their quality of life is least limited. So the decision has to be made very early and very individually.
The last question is, if you could tell us, how do you manage the problem with mask for non-invasive ventilation for your patients?
Thank you. So, a very important point is to have a broad spectrum of different interfaces. So, the wearing off by the skin, the compression of the skin with the mask is a major issue. So, we usually would ask our patient to test different types of interfaces which are best for them. When they come to our centers, we let them try several types, and most of our patients would have at least 2 different interfaces to switch and allow a rest for their irritated skin. Patients which require a long time or 24 hours daily non-invasive ventilation would frequently use mouthpieces, which has minimal contact with the skin of the patient, but requires wakefulness. But on the other hand, when they sleep, they would have frequently full face masks. But many patients would use nostrils, would use only nasal masks. So again, the broad spectrum of different interfaces is very important to maintain the quality of life and healthy skin on the face in our patients.
Thank you very much. It was last questions for your presentation. Thank you for long and very comprehensive presentation of the issues and barriers in good quality care if there is not multidisciplinary and not connected with whole system, regarding also the connection with physiotherapists and all other specialists with nutrition, and also neurologists if we are talking about some neuromuscular disorders. Thank you very much.